Uh, Good evening,
just
sir.
a second. Sorry for the inconveniences. I request Javinder to introduce Madam once again because just now started live. Sorry, people who are new in the Zoom and this thing.
We are live now, sir.
Yeah, just now live. So can you introduce once again, Madam and
yes,
candidate, please.
we are beginning with the first case. So first case is a case of congenital hypothyroidism, and it will be presented by Dr. Pooja Soni. She is a postgraduate student, third year postgraduate student at AIMS Bhopal, and she has been guided by Dr. Mahesh Maheshwari and Dr. Deep Sikha. Dr. Deep Sikha is senior resident at AIMS Bhopal, and Dr. Mahesh Maheshwari is professor and in charge pediatric endocrine services at AIMS Bhopal. And he is an active academician and involved in various IFP activities and other academic events. And the examiner for the first case is Professor Vandana Jain. She is in charge of pediatric endocrinology at AIMS Delhi. And ma'am is actively involved in academic and teaching for last 15 years. And she has many publications and book chapters under her name. So we are beginning with the first case of congenital hypothyroidism. Dr. Pooja, can we start?
Good evening, all.
Yeah, Ria, can you make Pooja host, please? She's unable to share.
Yes, it's done, sir.
Yeah. Thank you.
I'm not able to share the screen, sir. It's showing host as disabled participant screen sharing.
Ria, share screen करना है, host बनाना है. You can tell the history till then, or
Good evening, respected teachers. Sir, my screen is visible, sir.
yeah.
Yes, it is visible.
Good evening, all. Today I'm going to present this case of 4 months old female child, resident of Bhopal, Madhya Pradesh, belonging to upper middle class, presented with complaints of inadequate weight gain since birth, and she has not achieved age appropriate milestone according to parents. The increased letharginess for last 15 days and increased progressive pallor, for which she has received blood transfusion 15 days back. In detailed history, she was a late preterm born. At 36 weeks, she was a very low birth weight baby born at 1000 grams of birth weight, born to a 30 years old mother with gestational hypertension, which was controlled on medication. And after delivery, she cried immediately after birth. And she had an NICU stay of 10 days in view of prematurity, very low birth weight, respiratory distress syndrome, for which she required oxygen support for 1 day, and hyperbilirubinemia, for which phototherapy required for 3 to 4 days. She was discharged on day of life 10 with weight of 1.25 kilograms. After discharge, child was apparently well, but was not gaining adequate weight, and developmental milestones were she didn't gain developmental milestone as compared to the elder sibling. But but parents did not seek any medical consultation for same, and no screening test was performed. At 4 months of age, the child came to AIMS in view of inadequate weight gain. And since she has gained only 250 grams. Hello, yes, sir.
Go ahead.
She presented at 4 months of age with complaints of inadequate weight gain since she has gained only 250 grams in last 4 months from 1.25 to 1.5 kilogram, and delay in development since child was not able to hold her neck or she was not smiling, and increased letharginess for last 15 days and progressive pallor, for which she received 1 blood transfusion from outside. There was no history of cough, cold, fast breathing, vomiting, loose stools, or crying while urination, or feed intolerance. There was no history of constipation or TB contact. There was no history of abnormal body movement or staring look. No history of forehead sweating while feeding or suck cycle. There was no history of abdominal distension or skin rash. On developmental history, in gross motor milestone, on supine sitting posture, there was no neck holding, and she was on sitting posture. She was sitting with rounded back. On pull to sit maneuver, there was complete head leg. On ventral suspension, she was able to lift head momentarily. On prone suspension, prone positioning, there was partial extension of hips and knees, and she was able to lift her chin momentarily. On vertical suspension, stepping reflex was present. On fine motor milestones, grasp reflex is present. In social, adaptive, and language milestones, she was able to follow dangling object up to 90 degrees, and she was alert to sound. Social smile was absent. Hence, the developmental quotient for her corrected age was 33%, and developmental age is 1 month. In family history, she is the second born child born of non-consanguineous marriage. There is history of hypertension and type 2 diabetes mellitus and paternal grandfather, and he's controlled on medication. Maternal aunt has hypothyroidism, which is also controlled on medication. There was no history of similar illness in family or any history of sudden infant death, any stillbirth, or TB contact. The child was unvaccinated till now, and BCG scar is absent. On nutritional history, she received express breast milk feeding, and mother quantified it like 400 to 450 ml per day. She was not on any supplements. She was receiving total 290 kilocalories, approx 290 kilocalories of energy per day against her recommended intake of 500 kilocalories. That is deficit of 42%, and she was receiving 5 grams of protein per day against 6.9 grams of RDA. That is deficit of 27%. On anthropometry, the current weight is 1.5 kilogram. The median weight for her age is 5.8 kilogram. That is coming below -3 standard deviation. Her length is 40 centimeters, and the median for this age is 59.8 centimeters. That is also below -3 standard deviation, suggestive of severe malnutrition. Her head circumference was 31 centimeters against a median of 39.5 centimeters. That is also below -3 standard deviation, suggestive of microcephaly. And she has gained 500 grams weight in last 4 months, 3 centimeters of length in last 4 months, and 1 centimeter of gain in head circumference. On general physical examination, child was awake but lethargic. Vitals for heart rate was 108 per minute. It was regular. Respiratory rate is 46 per minute. That is abdominothoracic type, regular with normal depth. SpO2 is 98% on room air. Capillary filling time is below 3 seconds, less than 3 seconds. Temperature is 98.4 degree Fahrenheit, and blood pressure was 78 by 50 millimeters of mercury. On head to toe examination, the head shape of head is normal. Hairs were normal. Anterior fontanelle is open, and it is of 4 by 3 centimeters, pulsatile at level. Posterior fontanelle was normal, was open, and it was of 2 by 1 centimeters. She was having coarse facial features. At birth, she was having these were the facial features at birth, and at 4 months of age, she has developed some broadening of nasal bridge and protrusion of tongue, large tongue, and some coarse facial features. Oral cavity examination was normal. There was no abnormal mass was able to detect. Hearing was normal. She was alert to sound. On neck examination, there was no palpable mass. Skin and nails were normal. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Genitalia were normal. Coming to systemic examination, On central nervous system examination, she was awake, but cry was weak and physical activity was reduced. Cranial nerve examination was normal. On motor examination, tone was reduced in all 4 limbs. Power was 4/5 in all limbs. Deep tendon reflexes are 1+, and superficial reflexes were normal. Plantars were bilateral extensor. In neonatal reflexes, primitive reflexes, Morris reflex was absent, tonic neck reflex was present, and stepping reflex was present. Sensory system examination was normal, and there was no cerebral side, there was no nystagmus visible. On per-abdomen examination, abdomen was soft, and there was no significant finding in other system examination. Abdomen was soft and non-tender. There was no palpable organomegaly. On cardiovascular system examination, S1, S2 was heard, and there was no audible murmur. On respiratory system examination, bilateral air entry was present and equal, and there was no added sound. Coming to the summary of my case, it is a preterm 36-weeker born child, very low birth weight with birth weight of 1000 grams, second born female child with NICU stay of 10 days in view of low birth weight, respiratory distress syndrome, and neonatal hyperbilirubinemia requiring phototherapy with current chronological age of 4 months and corrected registrational age of 3 months. She was an unvaccinated child with global developmental delay, presented with poor weight gain since birth and increased letharginess for last 15 days with progressive pallor, requiring 1 allicate of blood transfusion from outside. On examination, child was having severe malnutrition and microcephaly with large protruded tongue, coarse facial features, open posterior fontanelle, generalized hypotonia, and hyperreflexia. With these findings, our differential diagnosis were hypothyroidism, congenital infections like TORCH infection or tuberculosis, hypoxic ischemic encephalopathy, and metabolic disorders. Points in favor of hypothyroidism were she was having developmental delay and letharginess and failure to thrive. She was having large protruded tongue with coarse facial features. She was anemic. She was having pallor. She was having wide fontanelle and wide anterior fontanelle and open posterior fontanelle, and she was having hypotonia, hyperreflexia. The points against the hypothyroidism were that there was no history of constipation or prolonged jaundice, and on examination there was no dry skin or umbilical hernia. Points in favor of congenital infections were developmental delay, letharginess, and microcephaly, and points against congenital infections were there was no history of hearing defect or skin rashes, jaundice, respiratory distress, or on examination there was no organomegaly or cardiac involvement. Points in favor of hypoxic ischemic encephalopathy were gestational that mother was having gestational hypertension, and this was a premature and IUGR child with developmental delay, failure to thrive, and hypotonia. And points against hypoxic ischemic encephalopathy was there was no history of birth asphyxia or seizures. Points in favor of metabolic disorder were like this child was having developmental delay, letharginess, and she was failure to thrive, and she was having microcephaly. But point against metabolic disorder were there was no feed intolerance and there was no organomegaly. So we went ahead with investigations. CBC, LFT, RFT were normal. She was having hemoglobin of 12 with total leukocyte count of 7,450 and platelet count of 4.69 lakhs with normal differential counts. Urea creatinine were 12 and 0.31 milligrams per deciliter. Electrolytes were sodium was 138 millimoles per liter, potassium was 3.9, and chloride was 102 millimoles per liter. Total bilirubin was 0.8 milligram per deciliter with direct fraction of 0.1 milligram per deciliter and indirect fraction of 0.7 milligram per deciliter. AST ALT were 25 and 15 units per liter. Total protein was 6.9 gram per deciliter and albumin was 3.8 gram per deciliter. LP was 125 and GGT was 22 units per liter. On further evaluation, the arterial blood gas was done, which showed normal parameters, and urine pH was also normal. On thyroid function test, she was having TSH of more than 150 microunits per ml with free T4 levels of 0.6 nanogram per deciliter. Her gastric aspirate for AB and CBNet was sent twice and it came negative. Torch profile was negative and transfontanel USG was also normal. So in view of history of developmental delay with letharginess, with examination findings showing failure to thrive, large protruded tongue, coarse facial features, anemia, open posterior fontanelle, hypotonia, and investigations showing high TSH with low free T4. We made a diagnosis of congenital hypothyroidism. For further localization and further assessment, USG of neck was done, in which there was no visualized thyroid gland in neck or oropharyngeal region. Further, we went ahead with thyroid scan, in which there was no visualization of any thyroid tissue in normal thyroid bed or elsewhere in neck or mediastinum. Hence, diagnosis of thyroid agenesis was made, and child was started on thyroxine supplementation at dose of 15 microgram per kilogram per day. And this child gained 1 kilogram weight in next 2.5 months, and developmental milestones also improved. Currently, the child is of 3 years of age, and currently anthropometry and developmental milestones are appropriate for age. Thank you, ma'am. Thank you, sir.
Now I request Vandana Madam to proceed further and ask any questions. Thank you,
So,
ma'am.
Dr. Pooja, I hope I'm audible.
Yes, ma'am.
Okay, so in this case, this baby was extremely low birth weight, preterm baby. So in your case, I think newborn screening was not done, but suppose it was done. Could you have still missed this baby on newborn screening?
Yes, ma'am. Since this was a premature child, so in premature child there is late surge of TSH. So if we do this if we do at the regular TSH screening at after 72 hours, we can miss our diagnosis. Like we need to repeat it after 3 weeks.
Yeah, so that is one very important point. The other thing is that you found microcephaly in this child and very severe developmental delay. So can you tell us the reason why it happened? Why did the baby have so much of microcephaly? How does thyroid impact the brain development?
Ma'am, this child was a preterm and IUGR child, born, and mother was also having gestational hypertension. So this might be one reason behind this severe microcephaly. And the thyroid. Sorry,
yes,
ma'am.
please continue.
Yes, ma'am. And another thing, thyroid hormone is required for the normal growth of normal growth and proliferation differentiation of neurons for normal brain development in the fetal and early infantile age.
Yes, so that is very important that basically for everything, for neuronal development, migration, synaptogenesis, for glial cell development and differentiation, for everything thyroid hormone, thyroxine is required. So definitely it can cause microcephaly, although typically it is like not described as one of the features. We typically see open AF, PF and developmental delays. Microcephaly is not typically described. Maybe the other features like IUGR and prematurity was also contributing. Okay, so I think you made a good presentation. So Dr. Amarnath, can we move to the talk?
Yeah, ma'am, if there are no questions, then we can go to the talk.
Can you look at the chat and see if there are questions?
Can we ask?
There are no questions in the chat, ma'am.
I think
Can I ask any questions?
Yeah, Dr. Ravind, sir, you want to ask question?
Yeah.
Yes.
Thank you, Dr. Pooja.
Just a second, sir. Dr. Ravindra, sir, is the in charge of pediatric endocrinology and neonatology at Municipal Hospital and Indira Hospital, North Delhi. Welcome you, sir. Sir is also examiner. And we request you to ask all the questions relating to pediatric just like a final exam. Not only hypothyroidism, any case, anything you can ask. Open for discussion and other people can answer your questions in chat box. Thank you.
Thank you, Dr. Amarnath. And first of all, very interesting case and very good case, Dr. Pooja. However, I am surprised this baby was discharged at the 1.25 kg. From where it was discharged? Because this is not a policy to discharge a baby with just 1.25 kg. It was a hospital delivery, must be a premature delivery, and then it was discharged from a hospital because baby has been treated at some hospital, and because baby was having couple of complications, for example, neonatal hyperbole. So how baby was discharged at 1.25 kg weight? It's a pretty, too low weight to discharge.
Yes, sir, definitely, sir. Thank you for the question. But this child was born in the outside hospital and she was discharged on day of life 10 with the weight of 1.25 kilograms.
So do you think it was right to discharge at 1.25 kg?
No, sir, it was not an appropriate weight for discharge.
What, in your opinion, should be the appropriate weight when a premature baby should be discharged?
Sir, premature baby can be discharged by weight of 1.8 to 2 kilograms. Like when she,
second question is, there is a history of MTP in second, third, and fourth delivery. Why it is so?
Sir, mother didn't want to progress this conception, so she went with MTP.
No, there must be something more than that. She got 3 abortions, and after then, still she is having 5th time she is opting for a baby. So there has to be something for that.
There was no exactly reason, sir. The mother didn't want to continue the pregnancy, and that's why she decided to abort.
I think you must grill mother more. This history is slightly unlikely. I mean, mother is having 3 abortions and then on 5th one, something is there. Can you find any reason for IUGR? Have they taken antenatal care? Because 1 kg baby at 36 weeks of gestation, it's a severe, SGA baby. Obviously, must be having many complications. One of them may be microcutly. So, what was the reason of such IUGR? Have they taken antenatal care?
Sir, mother was having gestational hypertension also. So that
but
might
it was
also be
one. As you have written with medicines.
I'm sorry, sir. Pardon, sir.
You have written that with medicine, this gestational hypertension was well controlled.
Yes, sir. But in the initial, first trimester, mother didn't received adequate nutrition also. So that might also be a
have been investigated. She has gone some antenatal ultrasound scan to know why such a severe IUGR.
She
at 36 weeks.
She went for ultrasound in her last trimester. At that time only she was told that she is having a small baby as against the gestational age.
Okay. And why she was giving expressed milk rather than the breast milk?
Because this child was not able to suck properly, sir. Also, the child was only 1.25 kg when she was discharged. When she was not able to suck properly, so that's why mother was giving her expressed breast milk.
You said baby cried immediately after birth, but still you kept diagnosis of HIE.
Sir, that was one of the differential diagnosis because this was a premature child and mother was having gestational hypertension. So still there was a antenatal event can also cause HIE, hypoxic and ischemic.
That would have been presented at birth. Baby would not be crying. Have APGAR score was available?
No, sir. It was not available for us, so we were not sure.
Have you done the knee X-ray of this baby?
No, sir.
Could it make any difference of getting a knee X-ray, or is it indicated, or it is of no relevance? Dr. Pooja, I hope I'm not very, these are simple questions. I don't think I'm going to be.
No. I think you can continue. She's having an answer of almost all the things.
yeah, that is true. But I'm having a impression probably.
So Pooja, is there any role of doing any X-ray in congenital hypothyroidism? So this is what Dr. Ravindra is asking.
Yes, Dr. Pooja.
Pooja, are you here?
Yes, sir.
So is there any role?
Yeah, you are doing great. Obviously.
Yeah, Disha, you can also answer. Other postgraduates who are there, they also can answer if they want.
They can put in, I think, chat box. because they can't
Yeah,
write.
other people can answer in chat box.
And even X-ray is a very good whenever you are thinking of congenital hypothyroidism, because then epiphysis will be absent, and you might be thinking that probably it's a case of severe hypothyroidism. And then you treat on a higher dose, as you have very rightly done, that you started the treatment with 15 microgram per kg body weight. I know there is a 10 to 15 at any way you can start. Thank you, Dr. Pooja. Really nice, interesting case. Thank you.
So, ma'am, there is one question in the chat box. So they have asked if we are starting with a dose of 15 microgram per kg at 3 months, then we have to continue with the same dose, or so we have to taper the dose. And if we want to taper, at what rate we should taper the dose of thyroxine?
So Pooja will be answering, or do you want me to answer?
So,
Dr.
Pooja, can you answer this question? So how to do the tapering and how to do the follow-up, actually, that's what the question is.
Yeah.
How to do the follow-up in these scenarios?
Sir, in the for the congenital hypothyroidism, at the beginning when we start the thyroxine, then initially we first of all we do repeat the thyroid function test after 2 to 3 weeks, and then for follow-up in the infantile is we repeat the thyroid levels, TSH and free T4 levels every twice a month, and after that we can do it every 2 to 3 months.
Yeah, Pooja, here question is different. Please understand the question. Do you want to stop all the cases of congenital hypothyroidism at the age of 3 years or not? First question. Second, if you want to stop, will you stop after the age of 3 years?
So first thing is we need to differentiate. We need to find out that whether it is a transient hypothyroidism or it is a primary permanent hypothyroidism. So if it is transient hypothyroidism, then we can stop it. But if it is permanent hypothyroidism, then we need to continue. But we can taper the dose.
So I think I'll just like to add here, Pooja, that basically you won't know whether it is transient or permanent. One way of knowing is that if your dose requirement goes down. So initially, of course, you start with 15 microgram per kg, and that is the answer to that question also. But obviously, you don't continue with the same dose, because as the child grows older, the dose requirement in terms of microgram per kg, it goes down. So typically, in fact, even if you start with 37.5 or 50, the child would continue to require the same dose, and per kg dose would actually go down. And most investigators would say, or authors would say, that if your dose requirement is less than 2 microgram per kg, then that is an indication that most likely the baby was having transient congenital hypothyroidism, and you can give a trial of treatment. Or in cases where you had not investigated properly initially, a nuclear scan was not done, or you had started it on dubious grounds, borderline TSH elevation, then you should give a trial of treatment at 3 years of age.
So one more question is there. Even if we start the treatment at the age of 4 months, will there be any developmental delay or mental retardation? Dr. Pooja, you can answer this. So if the therapy is started at the age of 4 months, will there be any developmental delay or intellectual disability in the child?
So some amount of mental retardation or can be there, but if we start as early as possible, then the severity of the mental retardation will be less for the age. So thyroxine is
what is the preferred age to start the treatment? How early you should start?
It should be started as early as possible and within 1 month of age.
So it should be started within 2 weeks of life. So that's why the newborn screening has a role in congenital hypothyroidism. So we want to screen all children. We want to detect it early, and we want to start the treatment as early as possible, preferably within 2 weeks of life. It should be started.
Yeah, Javinder, just I want to add for the first question. There is no need to stop hypothyroidism treatment if etiology is worked up very properly. Like in case of agenesis, you have worked the ultrasound thyroid absent, thyroglobulin level you have done absent, and also technetium 99 scan. Ectopic thyroid, you know. So where the chances are there, like you are taking the technetium scan, it is showing the uptake, but actually ultrasound discrepancy is there, or even disharmoniasis some cases. We don't want to stop in all the cases where the doubt is there, then you can stop. So where the high level of TSH is there. And my professor used to say, you have to do dilution technique. TSH may go up to 3000, 2000 like that. It's the best way to practice to know the TSH in the beginning. Thank you.
So, Dr. Ahmed, there are no more questions.
Yeah. Just want to add here.
Yes, sir. Yes. Yes.
That this is a common situation, especially in preterm infants. The neonatologists are very busy treating the prematurity, and newborn screening is always forgotten, quite often. And such babies, as already said, should have screening at the age of 2 weeks or 3 weeks and should not be forgotten. And in that case, we can avoid developmental delay altogether like anybody else. And I would also like to know the socioeconomic status of this family, because I mean, not that it matters, even educated people can sometimes make mistakes. And in this case, who is to blame? Is it the parents? The way Pooja was mentioning, it looks like she's blaming the parents, but why not the doctors? The parents also, I mean, the doctors also share equal responsibility. And one more thing I want to say is parental education. They should be given a talk about the usefulness of thyroid, and agenesis means lifelong treatment. The parents should be educated. That's also very, very important. And we must remember all their questions should be answered and the lifelong treatment should be insisted on. And as already Amarnath has said, because diagnosis is already proved, there is no need to do stopping that treatment at 3 years. And it's done only in cases where the diagnosis is in doubt. And have you put my slides on?
Yes, sir, your slides. These are the classical cases.
And there is no point diagnosing at this stage.
Yes.
Definitely there will be some developmental delay and even growth delay. And we may be happy making this diagnosis, but it is not really required. I mean, this situation can be avoided if newborn screening is done. Okay, my slides are different.
Yes,
what
sir.
I
Thank you.
to show today. I'll show it later.
Yes, sir. Over to Madam. We request Madam to continue with the congenital hypothyroidism lecture. Thank you, Madam. Madam is a professor of pediatric endocrinology from All India Institute of Medical Sciences. Has many publications and lot of work in she has done in congenital hypothyroidism. Thank you, Madam.
Okay, thank you. Really, it's a very good initiative by ISPE. I really look forward to more and more participation from the postgraduates for this PEP. So I hope my slides are visible.
Yes, Madam, visible.
Yeah. So Pooja has already introduced the topic and everybody has given their very valuable input. So I'll be quick about this topic. So congenital hypothyroidism, as we know, it is the commonest preventable cause of mental retardation. And worldwide incidence is 1 in 3 to 4,000 live births. But in Indian studies, the incidence is even higher, ranging from 1 in 1,100 to 3,400 live births. Coming to embryological development, the importance of thyroid gland is, justified by the very fact that it is the first endocrine gland in the body to develop. It develops as an outpouching of the endodermal epithelial cells from the foregut that is pharynx, at foramen cecum at 3rd to 4th week of gestation, as early as 3rd to 4th week. And then it migrates to the thyroid bed by about 7 to 8 weeks. And this path of migration is the tract of the thyroglossal duct. And this migration can lead to some developmental anomalies, most importantly, thyroglossal cysts, and also ectopic thyroid and hypoplasia or agenesis. This picture here shows a child with ectopic thyroid gland. Fetal physiology, the synthesis and secretion of T4 and T3 also start from as early as 12 weeks of gestation. However, the HPT axis is not well developed, and fetal TSH, TRH, they are very low until 18 to 20 weeks. And therefore, the fetus depends on the transplacental passage till then. But what is conveyed from the placenta? We'll come to it in the next slide. So thyroid hormones, they influence all aspects of CNS development. In hypothyroid fetuses, because of transplacental passage of thyroid hormones and also increased conversion of T4 to T3, T3 is the active hormone. Please remember that the major hormone which is secreted by the gland is T4, but it is converted peripherally into T3, and this T3 is the bioactive hormone. So there is increased conversion in fetal brain by type 2 deiodinase, so therefore there is neuroprotection. Sorry. However, in severe iodine deficiency, so both maternal as well as fetal synthesis of thyroid hormone is compromised, and that is why these babies have neurointellectual impairment. So this slide is showing the interaction of mother, placenta, and fetus. Remember, placenta also has a very important role in pregnancy. So placenta secretes increased estrogen. There is HCG. HCG acts as LH, and LH, as we know, which will act as TSH. So this will also increase, this will cause increase in T4 production in the mother and reduce TSH. And also this estrogen causes increased TBG in the mother. This leads to increased total T4 and T3 in the mother. This HCG also actually goes to the fetus, and there also it will act by stimulating the thyroid gland. Placental TRH as well as maternal TRH, they easily cross the placenta and reach the fetus. Maternal TSH does not cross the placenta. T4 and T3 cross the placenta, but not in entirety. So a large proportion of the T4, which is trying to cross the placenta, is actually deiodinated into the inactive form here. So only a small proportion crosses, not the entire thing. And that is why the peripheral conversion of this T4 to T3 in the fetal brain, that is also very, very important for neuroprotection. Coming to thyroid hormone synthesis, iodide is the main thing which is required for thyroxine synthesis. It constitutes 65% weight by weight of the thyroxine hormone. So this trapping of iodide and then converting it into iodine, these are the most important steps. So for the trapping, it requires the sodium iodide symporter. And then this is present in the basal membrane of the thyroid follicular cell. Look, this is the thyroid follicular cell. This is the colloid in between, and this is blood. So from the blood, iodide goes inside. Then at the apical membrane, there is another channel, which is pendant, through which it goes into the colloid, where thyroglobulin is already present. Thyroglobulin is also synthesized in the thyroid follicular cell and then secreted into the colloid. And then in this thyroglobulin, there is iodination of the tyrosine residues. And then these are again endocytosed and then finally released into the circulation. And as I told you, thyroxine constitutes the most important hormone which is secreted, but then it is peripherally converted into T3 as well. And for all of these actually steps to become active, binding of TSH to TSH receptor. TSH receptor is also present on the basal membrane. So that binding is also very important. So physiological changes in TFT during pregnancy. So as I told you, there is increased total T4 and T3 level and low TSH. Why is TSH lowest in first trimester? Because HCG is highest. So HCG is acting like TSH. It is causing increase in total T4 and T3, and this increase in total T4 and T3 are leading to feedback inhibition. So TSH is, what is the importance of this? That TSH cutoff values are supposed to be lower for diagnosis of hypothyroidism in pregnancy. In first trimester, if maternal TSH is more than 2.5, and if it is more than 3 in the second and third trimester, then this mother should be considered as likely to be having hypothyroidism. Then perinatal changes in thyroid function. So we are all familiar that very soon after birth, so within 30 to 60 minutes after birth, there is a rise in TSH, and this rise is very phenomenal, rising to as high as 60 to 80 microunit per ml. And then there is a quick fall also. Quick fall falls to about 20 milliunit per liter in the first 24 hours, and then further decreases to less than 10 by the end of first week. Why does this happen? Because of intrapartum stress and the cold extrauterine environment. What happens to T3 and T4? They also show a rise and then a fall, but the fall in T4 level is more gradual, and this decline occurs over 4 to 5 weeks. In preterm infants, there is a similar response, but this is blunted, and that is why they don't have as high TSH in the perinatal period as the term babies. So coming to etiology of congenital hypothyroidism, it can be permanent or transient. Permanent, the most important causes are thyroid dysgenesis, which constitute aplasia, hypoplasia, or ectopia, thyroid hormone biosynthetic defects or dyshormonogenesis, iodine deficiency, that is endemic cretinism, and hypothalamic pituitary hypothyroidism. So dysgenesis is the commonest cause. It affects about 1 in 4,000 live births and accounts for about 75 to 80% of all cases of congenital hypothyroidism. With agenesis accounting for approximately a third of these cases, are contributed by ectopia plus minus hypoplasia. The ectopic gland may or may not be hypoplastic. It is usually hypoplastic. It is like a normal thyroid gland, but it is because it is hypoplastic. So gradually the function goes down. In some children right at birth, they may have congenital hypothyroidism. In some, actually the initial levels may not be very much affected. They may be missed, or they may be considered as subclinical hypothyroidism, but gradually the thyroid function may go down. So it's not that all ectopic would present right at birth. Sometimes they may present with hypothyroidism later as well. So thyroid dysgenesis is typically sporadic. So it is not familial. It is typically sporadic. There is a 2:1 female to male preponderance. There are some genes which are implicated, but they are responsible in a minority, because as seen in many twin studies, in monozygotic twins also, there is a very poor concordance of congenital hypothyroidism due to dysgenesis. Coming to dyshormonogenesis, so we've already seen this figure. So there can be mutations in any of these pathways, like this sodium iodide symporter. It is encoded by SLC5A5 gene. So mutation in this gene can cause defect in thyroid trapping function. Then pendrin, we are all aware of this pendrin. So there is a pendred syndrome in which there is congenital hypothyroidism with sensory neural hearing loss. The same pendrin gene encodes for this channel, and this is present in the ear as well, and kidney also. Then the most important defect is defect in thyroid peroxidase. So this is the commonest cause for dyshormonogenesis. So dyshormonogenesis has been like classically taught as being responsible for 10 to 15% of all cases, and mostly autosomal recessive with goitrous hypothyroidism. However, these things are now changing. Now recent papers suggest that probably they can be responsible for up to 30% of all cases, and need not be always autosomal recessive. For example, mutations in DUOX-T2 or DUOX-A2 gene with autosomal dominant presentation also, sometimes they may present with hypothyroidism. Again, not all cases may be goitrous. This DUOX2, these are basically responsible for H2O2 production. H2O2 is responsible for this iodide to iodine oxidation. So when there is mutations, there can be a wide variability in their presentations. They can present as goiter or without goiter. They can present as permanent or transient congenital hypothyroidism. And now these are being recognized as a very important cause of congenital hypothyroidism. Then other causes are iodine deficiency. So as we know, our country still has pockets of iodine insufficiency, typically in the sub-Himalayan belt. So for example, even recent studies from Kangra, Himachal Pradesh, they have shown that up to 4% of cord blood can have TSH more than 20. So that's a very high level. So iodine deficiency can cause again transient or permanent hypothyroidism. Hypothalamic pituitary hypothyroidism, this is rare with an estimated incidence of 1 in 50,000, can be isolated or accompanied by deficiency of other pituitary hormones. Remember that if a newborn baby has microphallus, hypoglycemia, prolonged jaundice, always think about hypopituitarism and screen for it. Another important thing to remember is that sometimes, like I have seen in my own OPD, children presenting at the age of 1 year, 2 year with thyroid function reports and with TSH, which is normal, T4, which is clearly low, and people have missed that because we are just tuned to looking at TSH levels. So very important that all postgraduates should take this, that please look at T4 values also. So in central hypothyroidism, typically TSH is not low. TSH is like in the normal range. So don't think that TSH would be very low. TSH would be typically in the normal range, 2 to 3 microunit per ml, and T4 or total T4 or free T4 would be low. So genes associated with congenital hypothyroidism. So depending on, right from hypothalamus, pituitary to thyroid, various genes which are involved in hypothalamic pituitary development or TRS or TSH signaling, thyroid development like NKX2, FOXY1. These are responsible for some of the cases of thyroid dysgenesis, and thyroid hormone biosynthesis. So thyroglobulin, TPO, DUOX2, all these genes can be are implicated in congenital hypothyroidism. But a majority still remains sporadic. Thyroid dysgenesis, majority is still sporadic with no known genetic causes yet. So coming to transient hypothyroidism. So remember that transient hypothyroidism constitutes up to 25% of all cases. In fact, many papers don't actually report the long-term follow-up of their patients with who were diagnosed in newborn screening. But if follow-up is done, those papers that report follow-up till 2 to 3 years of age of children with congenital hypothyroidism identified on newborn screening, they suggest that up to 25% have transient form. And what are the etiologies? It can be primary or again central. So central can also be transient, primary can also be transient. It can be either iodine deficiency or excess. Excess will cause something called Wolff-Chaikoff effect. So when there is excessive iodine, basically the thyroid is adapted in such a way that it will protect the organism from thyrotoxicosis. So there is downregulation of the sodium iodide symporter as well as the TPO. So that is there is sort of shutdown of the thyroid hormone synthesis. So excessive iodine, for example, if a preterm infant is, a lot of betadine is applied, even that can cause transient hypothyroidism. Then maternal TSH receptor blocking antibodies, as in mothers with history of autoimmune thyroid disorder. Maternal anti-thyroid medications, both propylthiouracil as well as carbimazole, they can both cause hypothyroidism in a mother with Graves' disease. Then DUOX2 mutation, as I told you, it can cause permanent or transient hypothyroidism. And sometimes we see what is known as isolated hyperthyroidopeninemia. That is, TSH is high, but T4 is normal. Then again, central can be transient in case of maternal hyperthyroidism. So the fetal HPT axis is suppressed. In transient hypothyroxanemia of prematurity, we'll talk a little bit more about it. Drugs, dopamine. How does dopamine cause transient hypothyroxanemia? Dopamine causes dopamine as well as steroids. They both lead to inhibition of TSH secretion by the anterior pituitary. So these are both inhibitors of TSH. Then sick euthyroid syndrome, again in sick babies, sick preterm babies. It's not that, it's just that the HPT axis is immature. In sick preterm babies, there are multiple causes. So what do we see in such babies? That there will be low TSH along with low T3 and even low T4. So you can suspect that this is looking like central hypothyroidism. But this is transient and this is related to immaturity of the hypothyroidism, the HPT axis, as well as various medications. Okay. So in transient hypothyroxanemia of prematurity, again, this is something very important. So like I asked Pooja also. So in her baby, again, it might have been missed because if you do TSH, then TSH would be initially low to normal, but T4 would be low. So it can be missed, but many times when you see transient hypothyroxanemia, then what is it and does it need treatment? So it can be seen in up to 85% of preterm babies for up to 6 to 8 weeks. And it is primarily due to underdevelopment of the HPT axis, but also due to low iodine reserves and acute illnesses. Does it require treatment? So many studies have shown that on follow-up, whether the baby had transient hypothyroxanemia or not, it did not affect their IQ scores later. And whether the baby was given levothyroxine supplementation or not, it did not affect their outcomes in terms of physical growth or cognition. So there is usual sort of consensus that it should not be treated. And this table shows the normal ranges. And again, the main purpose of putting here is that you can see that TSH is more or less, it is not affected too much. But when we look at free T4 levels, so there is a very clear-cut rise in the free T4 levels as the gestation increases from 26 to 28 weeks. The median is just about 0.9, and at 35 plus, it is 1.4. So there's a very clear increase in T4 with gestation. At lower gestations, the free T4s are low. Coming to the most important aspect, that is newborn screening. So as amply advised by Dr. Raghupati also, newborn screening should be, universal newborn screening should be done for hypothyroidism because it is rarely amenable to diagnosis. Early diagnosis makes a very big difference in terms of the child's quality of life later, mental development. So it can be done either on cord blood or using a dried blood spot on day 3 to 5. And screening for preterm or sick newborns should be performed similarly. That is either cord blood or day 3 to 5. It should be done. It's not that it should not be done. It should be repeated later, but it should be done right as you would do in other infants. So various approaches. Most common is the primary TSH. That is, you only do TSH first. And backup T4, that is T4 is done only if TSH is elevated, more than 20. It is definitely most sensitive, but it can miss central hypothyroidism and hypothyroxanemia with delayed elevation of TSH, as happens in preterm babies. Then the other approach is primary T4 backup TSH, but obviously this can miss milder cases. And concomitant would be ideal, but expensive. So cord blood versus DBS. So either of these methods can be chosen. If you use cord sample, the benefit is that there is no extra prick to the infant. So if the baby is to be discharged early, as in many hospitals, then this is easy to do. Sample can be processed at any local lab. Training is not required. But the disadvantage is that the other disorders cannot be screened. Then postnatal heel prick by using filter paper. The advantage is that it can be used to screen multiple disorders, can be done for home deliveries also if a proper, this thing is in place, a program is in place. But it needs special assays. So typically Delphia is done and a reliable central lab. Adequate training is required to ensure error-free blood spots. And of course, there is some pain to the baby. So, but any of these methods can be chosen. So remember that the blood sample on the filter paper should be taken properly because only this will be eluted. So if spots are not covering the entire circle, then your value will be erroneous. Another important thing to remember is whole blood versus serum units. So if you're using a DBS, then of course what you're taking is a whole blood sample. So in whole blood sample, the level would be on the lower side. This level needs to be multiplied by 2.2 to be equivalent to the level in serum, because whatever interpretation we do is based on the level in serum. So if you're doing by DBS, the lab itself should report in serum units. It's not that the lab reports in whole blood and then you convert, but you should first check if you have started doing it, please check with your lab that they are reporting in serum units. Otherwise, you need to multiply by 2.2. For example, a TSH of 10 milliunit per liter in DBS would be equivalent to TSH of 22 milliunit per liter in serum. So they would, this should be ensured. Then if you do a screening TSH, then how to interpret it? So below 20 milliunit per liter is normal. In case the DBS was done before 48 hours, so at 24 to 48 hours, as we sometimes need to do in hospitals where discharge is to be done early, then the level has to be taken as higher. Less than 34 is considered as normal. And then no further testing is required. If the TSH level is between 20 to 40, remember we are talking about serum units, 20 to 40 million per liter or 34 to 40 in the early sample, then it is considered as a borderline screen value. And the TSH as well as T4 or free T4 are to be repeated at 7 to 10 days of life. If the level is more than 40, between 40 to 80, then again you have to obtain a venous sample, but you have to obtain it 72 hours. You don't have to wait till 7 to 10 because this is obviously high. So you will do a venous sample and initiate treatment if the repeat venous levels are abnormal. So you will wait for starting the treatment. If it is more than 80, then you don't wait for starting the treatment. You start treatment immediately but you do obtain venous sample before starting and send it to the lab. Excuse me. So based on the confirmatory venous sample at 72 hours of life, excuse me, if you have a high TSH, excuse me,
Madam, you have 3 minutes. Yeah.
Sorry, my throat is bad. So just quickly wind up. So based on the venous sample, again, basically, if you have low T4 and high TSH, then you have to start treatment. If your TSH and T4 are normal, then obviously no further treatment. If the TSH is high, but T4 is normal, that is TSH is more than 20 or more than 10 in more than 2 weeks old baby, then you have to repeat after 2 weeks and start treatment if the TSH persists to be more than 10 beyond 3 weeks of life. So coming to imaging, you should ideally do both ultrasound and nuclear scans. Nuclear scans are especially useful in diagnosing true athyrosis or ectopy. But if they can't be done immediately, then treatment should be initiated, and they can be done within 7 days of starting treatment or at 3 years after stopping treatment for 1 month. So some examples of thyroid scan: this is normal. Then this is no uptake, so agenesis. Here you can see that this is ectopic. This is almost at the base of tongue, and this is goiter with increased uptake. So presence of gland on the ultrasound, but no uptake on technetium scan. What does it suggest? Most likely maternal TSH receptor blocking antibodies, because the technate also has to go through the sodium iodide importer. And as I told you, TSH is important for the expression of sodium iodide importer. So remember that if you don't have universal NBS, but there is family history of congenital hypothyroidism, history of thyroid disease or antithyroid medicine in the mother, presence of conditions like Down syndrome, trisomy 18, congenital heart disease, or some other conditions like Pierre-Robin, where there is known high incidence of CH, then you should screen. And of course, in any infant with signs and symptoms of hypothyroidism, even in those with normal NBS, you should screen. So when should TSS screen be repeated if the initial screen was normal? In what situations? So in preterm infants who are born before 32 weeks, those with very low birth weight, acutely ill infants, those who have received blood or exchange transfusion, and in monozygotic twins, because in these, because of the blood, there may be dilution of TSH and you may have a normal value, and in those with Down syndrome. So in all these situations, you should repeat the TSH at 2 to 4 weeks of life, even if the initial screen was normal. So treatment already discussed, start with 10 to 15 microgram per kg per day. You have to keep T4 or free T4 in the upper half of normal range. In the initial 6 months, you have to first check for T4 and TSH 1 to 2 weeks after starting thyroxine, and then every 2 weeks till TSH is normalized, and then every 2 months till 6 months of age. Between 6 months to 3 years, every 6 months, beyond 3 years, every 3 to 6 months. Blood sample should be collected at least 4 hours after the last dose, and regular growth monitoring and developmental monitoring has to be done. There is query rising prevalence of CAH if you see the recent data. But in most of these cases, actually, we see that the incidence of dysgenesis has not increased, but there is increase in those with eutopic, that is normal thyroid gland on USG. And in follow-up studies of these patients with normal thyroid gland, roughly 35% have transient, 40% have permanent, and 25% have just persistent isolated TSH rise. So, and another important finding that has emerged from these various studies that I have listed here is that sometimes even TSH and free T4 at diagnosis cannot truly differentiate between transient and permanent. That is, some babies even with transient can have very high TSH and T4 and low T4. So more helpful predictor is persistence of a daily thyroxine requirement above 2 microgram per kg. And that is why a trial of treatment should be done in these situations. First, where treatment was initiated in the newborn period without complete evaluation or in preterm sick newborns. And second, where ultrasound is suggestive of normal thyroid gland or mild dysharmonogenesis, particularly those with a low thyroxine requirement. Obviously, in those in whom agenesis has been proven or the TSH is very, very high, and on thyroid ultrasound also you're not able to see the gland and the requirement is continuing to be high, there is no point of giving a trial of treatment. Best outcome is when thyroxine is started by 2 weeks at more than equal to 9.5 microgram per kg per day. But if treatment is started before 3 months, then more than 80% of infants have normal IQ, although they may have persistent minor learning defects. So key messages are that it is the commonest preventable cause of intellectual impairment, ideal condition for universal newborn screening. You all should have a high index of suspicion whenever you see any infant with various features such as developmental delay, ghost faces, constipation, dry skin, etc. Look at FT4 or T4 values also besides TSH. Please don't miss central hypothyroidism. Sick preterm infants may be missed on initial screening. Repeat testing at 2 to 4 weeks is important. Transient CH is also common, and trial of treatment is warranted in all infants in whom we are suspecting that the CH may be transient. And emphasize the importance of regular medication and follow-up to all families. In many cases, you see that despite very high TSH values, they still don't follow your treatment and continue to have poor control. And this is very frustrating sometimes. So emphasize this importance. Thank you. Thank you.
Yes, thank you very much, madam. We have some questions. I request you to answer in the chat box. So because of lack of time, we are moving to the next presentation. In spite of madam having the sore throat, you have given very extensive and elaboratively. Thank you very much, madam. So once again, we thank for coming, and we request you to suggest further in pediatric endocrinology for postgraduates. We'll move to the next case. Any comments or anything from the guide or co-guide? Yes, sir. Mahesh, sir. Last.
I think it is very well covered, and the question which were asked from Dr. Pooja is already answered by Dr. Vanna in her talk. So I think that is good enough. So I don't think there is any extra comment needs to be done.
Yeah, we thank team Madhya Pradesh, especially led by Mahesh sir and Ankita Maheshwari. Now we move to the next case by Dr. Disha Pandya from SAIMS Indore, and her guide is Dr. Ankita Maheshwari, Associate Professor from SAIMS, and examiner will be Dr. Ravindra Kumar sir. He is Vice President IIP North Delhi and also Professor from the North Delhi Municipal Medical College. Over to Disha.
Hello.
Yeah, please share the screen, please. You are audible.
Yes, sir.
Yeah, go ahead. Visible.
Okay. Good evening, everyone. I am Dr. Disha Pandya, third year PG resident, pediatrics at SAIMS Indore. We'll be dealing with the case of acquired hypothyroidism over here. So, starting from the history, a 14-year-old firstborn girl resident of Dhar district presented in PICU with complaints of difficulty in breathing, fever, cough, not gaining height, and lethargy. So, in detail, my patient was apparently all right 6 months back. Then she complained of difficulty in breathing, which was gradual in onset, progressive in nature, in the form that initially the dyspnea was on exertion, which further progressed to dyspnea even on routine activities. And since last 2 days, she had dyspnea even at rest. So there was progression from NYHA grade 2 to grade 4 that aggravated during supine position and partially relieved in sitting position. She had fever since last 2 days, which was insidious onset, low grade, undocumented, not associated with any chills or rigors or no diarrheal variation. Cough was there since last 8 to 10 days, which was insidious onset, non-productive, dry in nature, with no diurnal or postural variation, relieved on medications, with no complaints of any chest pain or hemoptysis. The patient also complained that she had lethargy since last 2 years in the form of excessive sleepiness and inertia in her routine activities. And according to her mother, the child was not gaining height since last 4 to 5 years as compared to her peers and not outgrowing her clothes and shoes. There was no history of any congenital heart disease in family or blue ejaculation of skin or any squatting episodes. No history of any loss of appetite or weight loss. Any history of Cox contact, blood transfusion, vomiting, loose stools or abdominal pain, or pain in joints, photosensitivity, malar rash, or any similar history in past. Child was a full-term vaginally delivered with a birth weight of 2.7 kgs. Her development was normal for her age. She was studying in 9th class and was average in studies. Family history, mother had history of hypothyroidism since last 7 to 8 years. She was on treatment of, she was on thyroxine tablet with a dose of 100 micrograms. So basically, this is a 14-year-old girl born of non-consanguineous marriage who presented to us with history of dyspnea, lethargy, acute cough, with non-contributory birth or past history, and with positive family history of hypothyroidism. So right now, we were suspecting a cardiac system to be involved, primary or secondary cause that had to be evaluated further, rather than a respiratory cause. Anthropometrically,
just a minute, go back. We request postgraduates to just think over the diagnosis at the end of summary. So when we are presenting in the final examination, either MD or DNB, at the end of summary, we should be able to tell the diagnosis. If you are not able, then you have to go to the examination. Just will give 30 seconds. All of you type your diagnosis, please. Yes, Disha, you can go ahead.
yes, sir. Anthropometrically, we saw that the child had a normal 35 kgs weight with a height of minus 5.6 standard deviation and normal BMI. So she was a short stature with normal weight and BMI with delayed bone age of 9.7 years. On examination, vitals, child was conscious. She had bradycardia, that is 80 beats per minute. Relative bradycardia was there with tachypnea of 40 breaths per minute. BP was 98/74, a little lower side, 5th centile for age and gender. Pulses were well felt, normovolumic with no radioradial or radiofemoral delay. She was maintaining saturation on room air. GVP was raised, that is 7 centimeters of sternal angle, with positive pulsus paradoxus and hepatojugular reflex was present. On general examination, child had a dull and apathetic look. She had dry skin, broad nasal bridge. Pallor was there, moderate grade. Knuckle pigmentation was present. SMR was prepubertal. She had bilateral non-pitting pedal edema. And there was no icterus, cyanosis, lymphadenopathy, or any other facial dysmorphism. On systemic examination, cardiovascular system, the apex was seen on inspection, apex was seen at 6 intercostal space lateral to the mid-clavicular line with no precaudal bulge, visible marks of dilated veins. And this inspectoral findings was confirmed on palpation also. There was no palpable P2 or parasternal heave or thrill. On auscultations, child had normal heart sounds at all the areas, but the heart sounds were muffled. Muffled heart sounds were present, with no murmur or pericardial rub. On respiratory examination, bilateral air entry was decreased, which was it was decreased more on left rather than the right side. Vesicular breathing was present and no other added sound. Abdominal examination was normal, and on CNS examination, cranial limb examination was normal. Tone was normal on all the limbs. She had the deep indent reflexes was normal, but had delayed relaxation. The DTRs had delayed relaxation. So, to summarize, this is a 14-year-old girl with pathological short stature, and on the basis of history and examination, we thought it to be possibly a case of pericardial effusion with lethargy and delayed puberty. We made most likely diagnosis, which we made was hypothyroidism. Second was Turner syndrome. As the child was short stature and presenting with delayed puberty, we should always think of a Turner syndrome. The other two diagnoses were on the downline diagnosis. These were least likely, but yes, tuberculosis and SLE. SLE as the child was adolescent girl, and a girl child, and the age group. On investigating further, we found that the child had macrocytic anemia. HB was 8.2, MCB was 102. Renal functions were normal. TSH was very high, more than 100 international unit per liters. Free T4 was low, 0.5 nanogram per deciliter. Electrolytes were normal. Anti-TPO antibodies were positive, that is 110 international unit per liter. Bone age, as I've mentioned, it was delayed, 9.3 years. Chest X-ray, I will show it in further photographs. There was a massive cardiomegaly was present in chest X-ray. This we can see the chest X-ray. There was massive cardiomegaly, and in the 2D echo we can see the pericardial effusion beside the cardiac wall. 2D echo was suggestive of a massive pericardial effusion with evidence of tamponade, though LVF was preserved, that is 60%. And USG pelvis had normal volumic ovaries and prepubertal uterus. This is the child, though we didn't have the photograph of the child of her pre-illness. We didn't have a pre-illness photograph of the child. So this is after the recovery. This is the chest X-ray showing cardiomegaly, and 2D echo showing massive pericardial effusion. So initially stabilization was done and urgent pericardial tapping was done. That is 450 to 500 ml of fluid was drained and was sent for sampling, and it showed an exudative fluid, nature of the fluid. It was an exudative nature of the fluid. And so we started the child on thyroxine with the rate of 1.1 macrogram per kg per day, of total of 37.5 macrograms per day. So final diagnosis we kept as hypothyroidism, autoimmune thyroid disease with pericardial effusion. We followed up the patients after 2 months. Improvement in symptoms were reported. There was 3 centimeter height gain in 2 months. TSH value decreased to 12.2 and free T4 came to upper normal range, that is 1.2 nanogram per deciliter. And 2D echo was done, which was suggestive of a normal LV function with mild pericardial effusion was there. After 6 months, we followed, there was a height gain of 5 centimeters in 6 months. As she started developing breast, that is, she started getting the pubertal changes. TSH was 4.5 and FT4 was 1.1. 2D echo was normal at this time. There was no pericardial effusion and normal LV function was there. I would just like to enumerate some of the causes of acquired hypothyroidism, that is autoimmune. It can be drug-induced, post-ablative because of irradiation.
Yeah, Disha, please stop. There is a lecture. We'll have that in that. So now the case is open for discussion. I request all the examiners. If you have any questions, please ask.
May I ask you questions?
Yes, sir.
Yes.
Thank you, Dr. Amarnath and Dr. Disha. It's a very beautiful and interesting case. I mean, hypothyroidism presenting as a cardiac tamponade. It's not a usual presentation, very unusual presentation. And it has been managed and investigated beautifully. And that's a full marks to you. However, I have a couple of questions for you. So what was the reason of fever in your case?
Yes, sir.
Was having fever. What was the reason of fever in your case?
Sir, we were suspecting some acute cause due to any illness, any viral illness maybe.
Any viral illness, okay. And mother was, what type of hypothyroidism mother was having? It was autoimmune?
Yes, sir, we suspected autoimmune hypothyroidism only, but we asked for any anti-TPO investigations if she had, but it was not available from her side, sir. But we were suspecting autoimmune hypothyroidism.
Yes, the reports were not available. What sort of hypothyroidism mother is having?
Yes, sir.
In anthropometry, by plotting on growth chart, you said SD minus 5 SD is height. So have you calculated SD in this 14-year-old girl? Because by chart it is IB chart you have used. They are saying less than third centile. You said
Yes, sir.
is somewhere I think -5 or some you show on
Yes, sir.
slides. So how you
Yes,
calculate
sir.
it as the in 14-year-old value?
So standard deviations are not on growth chart, but from the app we calculated the standard deviation.
Because if you
On growth
calculate
chart was
it,
-3.
this is the question which examiner may ask, or usually we ask over DNBs, how they calculated the SD in 14 years. Even I want to know. Then in CBS, you said S1 and S2 is normal, and then sounds are muffled. So if our sounds are muffled, obviously it can't be normal.
Sir, there were no added murmurs. They were heard.
Yeah, that
S1
is
and
okay,
S2
fine.
was heard.
See, if our sounds are muffled, muffled means it's very low pitch sounds.
Yes, sir. Low
So
pitch
S1
sounds,
and
but
S2
they were
can't be
heard.
normal because these are then it is all muffled.
Yes, sir.
Then in respiratory system, you said bilateral air entry decreased more on the left than right. So what
Yes,
about
sir.
percussion? Because it is giving me an impression of some pleural effusion. You said
Sir,
bilateral decreased.
yes, sir. So we also suspected that the child might have pleural effusion just on the basis of history, but on
It is more
percussion.
appreciable if you have written the percussion finding also.
Yes, sir.
Then
So it was,
in DD, you make first DD of hypothyroidism. Why? It's very uncommon. I won't make. Sorry. Hypothyroidism is very rare. Rather than we have the couple of more common things which can cause all these malnutrition. They may have cardiac findings. So why hypothyroidism as a first?
sir, first of all, the look of the child, the look was very apathetic and a dry skin was there. Secondly, the child was a short stature. So then there was a delayed puberty was there. Mother had we had a positive family history of hypothyroidism. And also the child had a history of excessive sleepiness since last 2 years. And there was a decrease in movement, she was a little slow in all her activities in last 2 years. And she had this history of lethargy. That's why, so all these things.
And all these features can be explained by tuberculosis very well, and which is more common and causing all these cardiac complications rather than hypothyroidism.
Yes, sir. Tuberculosis. Yes, sir.
But why at first instance hypothyroidism?
So, just by the look of the child and the history of lethargy and
it is difficult.
Mother had a positive history of
14 years of age by look. But anyway, hypothyroidism is good. But first diagnosis, hypothyroidism, something will be. You can put it second or third. Tuberculosis, which is very common, very rampant in our country, and it can cause anything.
Yes.
Prover goes for tuberculosis, it can cause anything except pregnancy. So all these malnutrition, short stature, delayed puberty may be there, which is simply short stature. Then USC pelvis, it's good. You have done, you said prepubertal uterus. Anything more we can ask to look for to just say that it is prepubertal, apart from just they have writing, means shape of the uterus, size of the uterus, volume of the ovary, all these things. Can it be done?
Sir, beg your pardon, sir. I didn't get the question, sir. Your voice was interrupted in between.
Okay. Ultrasound pelvis has been done just to know the pubertal status. So when
yes,
we are
sir.
writing ultrasound just to know the pubertal status, so it is more appreciable and knowledgeable if we know the shape of the uterus, it is tubular or pear-shaped, size of the uterus, what is the size, what is the volume of the uterus, what is the volume of the ovary, is there any follicles, how much is the number of follicles. And have you done, have you done any hormone investigation, LH and FSH in this case? Although, yes,
Sir.
that you have said it is clinically prepubertal.
By SMR reading, sir, we did SMR
We
reading.
have a couple of queries. Although you managed this case in a very good way. Obviously, it was because hypothyroidism causing it, and just give thyroxine and patient will be all right. That is true. Thank you. Over to Dr. Amarnath.
Yeah, thank you very much. Now I request any other examiners, including Dr. Mahesh sir and
Disha, good evening.
Good evening, sir.
Good evening. I think you presented very well. I'm having the first thing that I congratulate you and Dr. Ankita that you kept the hypothyroidism as one of the differential diagnosis in this child, because just like Dr. Ravindra is saying, there are many differential diagnoses that usually comes first when you're thinking about hypothyroidism. So I just wanted to know a few things from your presentation. What type of pericardial effusion you normally get in hypothyroidism?
Sir, we normally get an exudative type of pericardial effusion.
Okay, from my knowledge, I think it is primarily the transudate. Exudative collection is not that common. That can happen, but most of the time it is a transudate collection that was there. Maybe. And the second thing is, I just wanted to know that when you perform this thyroid interpretation, thyroid hormone interpretation, at that time, can you just explain about the sick thyroid syndrome? At what time you did, and can you just affecting your lab values and your interpretation? So, what is sick thyroid syndrome? And that may be the reason in the acute sick child, in the acute illness, you perform these investigation, and it turned out to be a picture of primary hypothyroidism. So that is the one other point that can be considered because you manage and the child is shown the response. There are other parameters also that can suggest that most probably the child is having hypothyroidism. So you manage them very well in that way. But I think as a postgraduate, probably you just need to think, is there this hormone assay interpretation is really correct at that particular time? Now, the third question is, what about the CPO antibody? You said it's 110. When we should say significant CPO, the titer should be how much times, then only you can consider it as a significant. Okay, so I think the next lecturer probably is going to answer these questions. So there are a few things that needs to be taken care whenever you think about this particular differential diagnosis. Well done, Disha.
Yes, sir. Thank you, sir.
Yeah, I request Raghupati sir, anyone has any questions, please ask. I have one question, Disha, for you. Very well presented. Suppose if I start full dose of thyroxine, can I start in this child? It's a chronic case of juvenile hypothyroidism.
No, sir. Sir, we
if
should
I start,
with
what will
dose.
happen? Why you should not start? Yes.
Sir, because the higher dose of thyroid will cause increase in BMR of the child, and that may further worsen. That may cause failure, cause CCF, or further worsen the CCF which the child already had. That's why we should always, in chronic hypothyroidism, we should always start with a low dose, and our target should be to maintain the T4 level at the upper normal range.
So, by community medicine, just I wanted to ask a question. What message you want to give to our fellow pediatricians and the pediatric postgraduates? Till 14 years, why child was missed?
Sir,
yes.
Sir, anthropometry. Anthropometry is the should
no.
Be
my question is community pediatrics. Why child was missed till this age, and how you would have been prevented?
Yes, sir. That's what, sir. Whenever a child is coming to your clinic, in earlier age groups, we should always we should never forget to take the anthropometry of the child. And other than this,
do you want to use the growth charts?
Yes, sir. Growth charts. Yes, sir.
Do you want to use the bone age?
Yes,
any
sir.
Child? Yes. So left hand and right hand of pediatric endocrinologist as a pediatrician for short stature, growth chart and bone age should be done in all patients. So take home message. Anyone has any other questions, sir?
I've got only one observation. I have many questions, but
yes,
don't want to prolong this. I just want to ask Disha.
Yes, sir.
You said tuberculosis as a differential diagnosis. Tuberculosis
Yes, sir.
is a very, very vague condition. Tuberculosis of what? And never
Sir,
tuberculosis. You must specify tuberculosis of what? Hypothyroidism and diagnosis of tuberculosis as a differential diagnosis is not right. You must say where.
Sir, most probably a disseminated tuberculosis that may cause any signs of pleural effusion or pericardial effusion. A disseminated
Do you expect a disseminated tuberculosis patient to be well enough to come to the clinic for short stature? Will the child not be very malnourished?
Yes, sir.
And that's not a diagnosis. I'm finding it very difficult to accept tuberculosis as a diagnosis. Okay, carry on.
Sir, any other questions, sir? You have one more question you can ask. Sorry, we have forgot you. Yeah. Now I request Ravindra Kumar, sir, to proceed for the acquired hypothyroidism presentation. And this presentation will be provided to you on Telegram. So please concentrate. Most important area. Don't take any notes or the pictures. We'll send you the PPT in your Telegram group. Over to you, sir. Sir is a great teacher, passionate, and we request you to, from the EC, on behalf of EC, here we 3 people are there, Dr. Ravindra Kumar sir, Mahesh sir, and me, and Ayla madam. We want you to see the congenital hypothyroidism video. Please don't forget and spread it to all the people. Over to you, sir.
Thank you, Dr. Amarnath. I think previous presentation has to be closed so that I can share my screen.
Yes, sir.
Disha, please.
I think I have to go to the
share screen.
Share screen, then I have to go to my
you open your presentation first, sir.
Okay,
then,
okay.
Then you share screen.
Is it visible?
No, sir.
Not yet.
Okay, just a minute.
Yeah.
I hope now it is visible.
Yeah, yes, sir. No,
yes, sir.
It is full slide visible?
No, sir. It's
No.
not in the screen.
Now it is full slide visible.
Yeah.
Yes, now you can go ahead, sir.
Good evening, everyone. And I think it's very nice discussion and 2 very good case presentation has been done today. And even I learned a couple of new things in this presentation and very good lecture by Dr. Vandana ma'am. And after that lecture, my job is little easy. So, and before I proceed for anything, I always pray to God to give us knowledge and wisdom to treat all these needy patients. So as we know, what is acquired hypothyroidism? The reduced production of thyroid hormone is a central feature of this clinical state, which is known as hypothyroidism. However, apart from reduced production, it may be reduced action of thyroid hormone at the tissue level, that which the normal increased thyroid hormone production of thyroid gland can also be associated with clinical hypothyroidism. Hypothyroidism, it is the most common disturbance of the thyroid function in children. Acquired hypothyroidism can be caused by both either thyroid disease known as primary hypothyroidism and hypothalamic pituitary disease, which is known as central hypothyroidism, as we see in congenital hypothyroidism. Primary hypothyroidism, which may again may be either subclinical, where the TSH level is increased but free T4 level is normal, or it may be overt, which is very clear-cut diagnosis. TSH is increased and serum free T4 is low, as we have just seen in this case. Apart from this, there are two very common terms they are used: autoimmune thyroiditis and autoimmune thyroid disease. However, these two are two different things. Autoimmune thyroiditis, it is the most common cause of acquired hypothyroidism, also synonymous with chronic lymphocytic thyroiditis or Hashimoto thyroiditis. If you look at the autoimmune thyroid disease, this is somewhat is a broader term, which is encompassing disorders with autoimmune mechanism that have a risk for both hypothyroidism and hyperthyroidism. Both may be the possibility. I mean, then there are certain features, clinical features, where we raise possibility of acquired hypothyroidism. As you know, congenital hypothyroidism, we do the universal screening. However, in acquired hypothyroidism, we usually have some clinical features where we thought of hypothyroidism and advise appropriate investigation. And common of these are short stature. Sometimes it may be just isolated presentation of hypothyroidism. Poor growth velocity, goiter may be visible, which raise the possibility of hypothyroidism, then dry skin, constipation, all of us are aware, sluggishness, as was in our last case, precocious puberty, which is not true, which is a pseudo precocious puberty, and apart from precocious puberty, maybe delayed puberty also. Macroorchidism in males, the weight gain may be there, which is not because of the obesity rather than the edema. Calf muscle hypertrophy, galactorrhea because of the increased production of prolactin, and cardiomyopathy or pericardial effusion or pleural effusion I have just seen in the last case. If you look at the findings on examination in primary hypothyroidism, the most common physical finding is presentation is usually a diffusely enlarged thyroid gland called goiter. However, alternatively, the thyroid gland may be normal in size or may not be palpable at all. Other abnormalities that may include short stature, apparent overweight, which is already said it is more because of the fluid retention rather than the obesity. Puffy faces with a dull, placid expression, bradycardia, pseudo hypertrophy of the muscles, delayed deep tendon reflexes, which is very, very important, as we have just seen in our last case. Abnormal findings on chest and cardiac auscultation may point to pleural or pericardial effusion, and these effusions, they resolve very well levothyroxine in treatment, as we have just witnessed. So we must not forget to put our stethoscope on chest and cardiac region, just to look for any abnormality there. If you look at the etiology of acquired hypothyroidism, it may be autoimmune hypothyroiditis, which is the most common. That may be iodine deficiency, as just Dr. Vandana has said. Still, it is prevalent despite being the salt being fortified with iodine, as we see in Kangra Valley of Himachal Pradesh, where still 4% of people found to be having low iodine status. There may be some drugs which is blocking either synthesis or release of thyroid hormones, and a few of them are antiepileptic drugs like phenytoin, phenobarbital, valproate, then lithium used in psychiatric disorders, anti-cancerous drugs like interferon alpha, thyroxine kinase inhibitors, interleukin 2, and to be very important, not to miss amiodarone. Could be because of the thyroid infiltration by cystinosis, LCH, or maybe because of the amyloidosis. Post-ablative thyroiditis, when hyperthyroidism has patient not gone into the remission, has been treated with radioactive ablation and landed in hypothyroidism later on. Post-thyroidectomy because of the surgery, and there may be some goitrogens in foodstuffs or endemic pollutants. However, how much it is relevant in Indian scenario, I mean, not known. Literature lists them. Then maybe secondary or tertiary because of the pituitary origin, which is the secondary. If there are hypothalamic disorder, then tertiary. Baxalton, it is again a retinoid X receptor agonist used in T cells lymphoma, causes the hypothyroidism. Then, as Dr. Vandana has already said about the dopamine, dobutamine, steroids, and severe illness, they all can cause hypothyroidism, but obviously transient in nature. Maybe because of the conjunctive hypothyroidism, because there is a rapid destruction of thyroid hormone because of the D3 expression in these large hemangioma, and more especially in liver. Then there are many disorders which are associated with the autoimmune thyroid disease. So we have to be very careful when dealing with these diseases. For example, Down syndrome, Turner, Klinefelter, or Noonan, they may present with thyroid disorders. Again, APS 2 and 1, type 1 diabetes, as there is always a dictum, the case of type 1 diabetes should be investigated for other autoimmune disease like thyroid disorders, then celiac disease, juvenile idiopathic arthritis, Addison's disease, cases of vitiligo, alopecia areata, pernicious anemia, and immune glomerulonephritis. They may have concomitant simultaneously thyroid problem and IPEX syndrome. Now, how to, after making the diagnosis, we have seen the clinical feature of a patient, we have examined the patient, we are thinking that probably patient may have thyroid disorder, may be suffering from hypothyroidism. So to assess the thyroid function, one can go for total T4 and T3 levels along with the indices that reflects the thyroid hormone binding proteins, especially T3 or T4 resin uptake. The level of free T4 are measured to assess thyroid hormone status without the confounding influences, especially all the carrier proteins. However, critical in the interpretation of all these hormone value is the recognition that these concentration of T4, T3, and TSH, they vary with the age. So one has to be very careful while interpreting the results, because most of the time what lab is giving is giving the adult reference range. But as Dr. Vandana has given a chart where, by the day and months, these labels changes. If after doing all these investigations, for example, T3, T4, and TSH, which is the baseline essential investigation whenever someone is suspecting thyroid problems. So there may be a couple of scenarios. For example, TSH may be elevated and free T4 is low. So that's a clear-cut diagnosis. When TSH elevation is more than 10 and low free T4, then it's a case of overt primary hypothyroidism. However, in addition, sometimes children with central hypothyroidism, they have a mild TSH elevation, although most of the time it is either within the range or low, but sometimes they may have a mild TSH elevation. That has to be taken care of in mind when you are interpreting the results of elevated TSH with low free T4. Another scenario may be when the TSH is elevated but normal free T4. This persistent elevation of TSH with normal free T4, that is again compatible with subclinical hypothyroidism. For patient with serum TSH is more than 10, treatment is required. However, for all those children which is having mild TSH elevation, somewhere between 5 to 10 milliunit, then the further elevation and monitor to determine either it is this TSH elevation persist or whether it is likely to develop clinically overt hypothyroidism or not. So this mild elevation of TSH, that is somewhere 5 to 10, it occurs to couple of scenarios. For example, in obesity, patient 10 to 23% of patient in couple of studies, they were having the TSH elevation. However, the free T3 and free T4 values, they were normal. So it was not case of overt hypothyroidism, rather subclinical hypothyroidism. Maybe one scenario where serum TSH is low or normal with low free T4. So these findings are consistent with the central hypothyroidism. However, as there was discussion, just Dr. Maheshwar discussing, may be found with non-thyroid illness syndrome also. So if thyroid function tests are obtained in a patient with acute or chronic illness, in acute illness, as has been taken in our case in PICU, they should be repeated after recovery from the illness before making a definitive diagnosis. A few children with central hypothyroidism, as already has said, they may have slightly high serum TSH because they are secreting the immunoreactive TSH, but this is not biological active, it is biological inactive. Hence, central hypothyroidism. However, while interpreting all these hormone levels, one has to be very careful about couple of scenarios where thyroid hormones, the levels are maybe abnormal, yet the individual is euthyroid. And to enumerate, two are very, very important. When free T4 values are normal, yet total T4 values are high, then should be thought of familial dysalbuminic hyperthyroxanemia. It should be considered as a cause. Family history should be taken. Otherwise, erroneously, these patients will be treated as a case of hyperthyroidism. If free T4 values are normal, but total T4 values are low, then deficiency must be entertained, so that erroneously again should not be treated as a case of hypothyroidism, while this is absolutely euthyroid patient. So we have to pay attention to total T4 values. It is high or low. If low, TBG deficiency is one possibility. If high, then familial dysalbuminic hyperthyroxanemia. Coming to the primary hypothyroidism, what are the further evaluation has to be done? So patient with overt hypothyroidism, if they are having elevated TSH and low free T4, may be tested to look for the autoimmune thyroiditis by measuring anti-TPO antibodies and anti-thyroglobulin antibodies. Anti-TPO antibodies will be present in 85 to 90% cases of autoimmune thyroiditis. However, anti-thyroglobulin antibody may be positive in just 30 to 50% of the cases. However, if a child who is having hypothyroidism and positive thyroid antibodies and having a palpable goiter also, then ultrasound examination may be done to obtain the typical hypoechoic and hyperechoic pattern that is known as moth-eaten or Swiss cheese-like pattern of autoimmune thyroiditis. If a patient sometimes has a markedly asymmetric goiter or a palpable nodule, ultrasound examination there comes very important to determine the size and echo characteristics of these goiter and nodules and determine if FNAC has to be done or is needed or not. Few words about subclinical hypothyroidism. In patient with subclinical hypothyroidism where TSH is elevated and normal free T4. So those with positive anti-TPO antibodies, they are at risk to develop overt hypothyroidism over time. However, not all developed, and this is a case when this TSH is somewhere between 5 to 10. If more than 10, the patient requires treatment, has to be treated. As already said, in children with obesity, mild elevation of TSH are common and may not warrant antibody testing if free T4 is normal. If there is a patient who is having no evidence of autoimmune thyroiditis, for example, normal TPO and thyroglobulin antibody, but persistently elevated TSH may be caused by the mutation is the TSH receptor genes, causing resistance to TSH. Although not very uncommon situation, however, has to be kept in mind. While evaluating the central hypothyroidism, the children who are confirmed should undergo cranial imaging with contrast, preferably MRI, because we want to know the status of the pituitary and test for other pituitary hormone deficiency, for example, cortisol, growth hormone, and other hormone, because patient may have hypopituitarism rather than having the isolated thyroid hormone deficiency. After making the diagnosis, going through the clinical features, then examination, then doing the biochemical investigation, when we know that we are dealing with a patient of hypothyroidism, then treatment of choice is tablet levothyroxine, which has to be given once a day. Timing is very, very important, should be given 60 minutes prior to the food consumption. As many times our older children, for example, 4 year, 5 year, 6 year, they may be taking iron, calcium, and soy products. So should not be given along with them. There should be a gap of at least 3 to 4 hours between these two medicines. Many preparation for thyroxine are available, for example, tablet, gel, or syrup. However, in India, as far as I know, it's only tablet is available, and this is good enough. Dose, although it changes as per the age from 1 to 3 years, as someone asking in neonatal congenital hypothyroidism. For how long? 15 microgram per kg body weight has to be given. So by the age of 1 year, those came down to somewhere 4 to 6 microgram per kg per day. But obviously, it has to be done along with the biochemical markers. 3 to 10 years, dose again goes down somewhere 3 to 5 microgram. 10 to 16 years, 2 to 4 microgram. And in adult, 1 to 1.75 microgram per kg per day.
Sir, for your attention, you have 3 more minutes. Thank you.
Okay, I'm just completing. To remember in a much better way, 100 microgram per meter square per day is better. Then we can know the body surface area and can accordingly calculate the dose. Follow-up, somewhat different from congenital hypothyroidism. Initially, after starting the medicine, 6 to 8 weeks after, it has to be seen that yes, after dose, our TSH has gone down, free T4 has come in the range. Then 3 monthly till linear height is achieved. Older children may be done at 6 monthly. TSH has to be maintained somewhere 1 to 3 micro-IU per ml. Free T4 to be maintained within the reference range of the age. Goal of the treatment, patient has to be hypothyroidism, should have normal growth and developmental, including the pubertal development. So these 3 parameters has to be seen on every visit rather than just seeing the biochemical investigation. Some precautions has to be taken for long-standing, full-blown, untreated hypothyroidism. As we're discussing, thyroxine should be started at a lower dose, somewhere 1/3 to half of the dose, and gradually stepped up over several weeks to reach full dosing, as has been done in the last case. Because if profound hypothyroidism will present, pseudotumor cerebri may develop, especially when dealing with the children somewhere 8 to 12 years of age, and they are treated with the conventional dose. The complication even may appear up to 1 to 10 months after initiation of treatment if we are starting the conventional dose. Thus, treatment is initiated with 1/3 to 1/2 of the usual dose of the levothyroxine, and after 4 to 6 weeks, patient can be advanced to conventional dose by a 1/4 dose increase every 4 to 6 weeks, so that full dosing may be achieved by somewhere 12 to 16 weeks. If we look at the algorithm for the acquired hypothyroidism, symptoms and signs suggestive of hypothyroidism, thyroid function test has been done, found to be abnormal. If TSH is normal, free T4 is low, then if free T4 is normal, TBG deficiency, hypoproteinemia. If normal TSH and low T4. And if free T4 is also low, then it is central hypothyroidism and accordingly has to be investigated. Another scenario where TSH is just slightly elevated, somewhere 5 to 10. Total T4 is normal, TPO antibody is negative. Most commonly, it is because of obesity and drugs. We may monitor these cases. However, if T4 is normal, but TPO antibody is positive, then it is better to monitor 6 monthly, because few of cases, they may land up into overt hypothyroidism. However, if TSH is more than 10, then treat and find the etiology. So clinical features, signs and symptoms which are suggestive of hypothyroidism, biochemistry has to be done, essentially TSH plus total T4 or free T4. T3 is more used for hyperthyroidism rather than the hypothyroidism. TPO antibody and antithyroglobulin antibody titers may be done. Imaging, ultrasound for primary hypothyroidism if necessary. But for central hypothyroidism, MRI brain has to be done. Thyroxine is a treatment of choice in appropriate dose, appropriate timing, which is very, very important. And if it is chronic or severe hypothyroidism, then in a reduced dose. Thank you.
Thank you, sir, for a nice talk. We can take a couple of questions.
Yeah, we don't have a time, Javinder, because already 9 o'clock we should end. I request Ravinder sir to answer in the chat box, because we have to complete another 2 tasks.
Oh.
Thank you very much, sir. It was excellent discussion for both case 1 and case 2. Thank you very much. Now we'll move to the next presentation, that is OSCE in Pediatrics, and this will be done by Associate Professor of Pediatrics, Dr. Ankita Maheshwari from SAMS Indore. Over to you, Ankita. Thank you very much for your support for giving the second case, that is acquired hypothyroidism case, which was a classical case with pericardial effusion. Over to you.
Thank you, sir. Sir, just wanted to ask Ravindra sir's one question. Sir asked Disha that from where we have calculated the standard deviation. So,
Yes.
sir, there is an app called Anthrocal, which you can download for free in iPhone as well as Android. And
Anthrocal, it is for US app or which is developed by AIMS?
No, sir. Up to 5 years, it gives WHO Z scores, and after 5 years, it gives IAP Z scores till 18 years.
Okay, thank you. Actually, that is why I was asking, because he has shown me this IAP growth chart. That is why I was asking. Probably he has tapped there are two apps. One is
Yes, sir, there
Anthrocal
is an
and other
app,
is developed by AIMS people.
Yeah, it's the same app which is developed by AIMS people, sir. Anthrocal.
Yeah. So that is the app. Usually we put a photograph of that. Thank you.
One more app is there, sir, which is anthropometric calculator. That's
Okay.
a app which is developed by outside people, and that app contains a lot of other useful calculations. You can calculate MPH. You can calculate predicted adult height in that app.
By BP table, they calculate by BP table. This adapted.
You have to just enter the born age by GP Atlas and chronological age of the child, and it will automatically give you predicted adult height.
Ankita, please you start sharing.
Sir, is my screen visible? I started sharing.
Yeah, but you start sharing.
Sharing. Screen is visible, sharing is not.
Already it's been sharing.
No, it has to be open.
You just click it again, Dr. Ankita.
Still not visible, kya, sir?
No,
because on my system it's showing that I'm sharing my screen.
Your computer is visible.
Stop and once again try.
The presentation is not you opened till now. So just open your presentation and then do it.
Already opened it.
No,
it's
you stop sharing, you do it again.
I'll share it. I'll do it again.
Yeah, for the introduction of OSCE, you should know each OSCE station.
Visible now?
Not it.
I'll share again.
So around 5 to 8 minutes. So each OSCE carries around 8 to 10 marks.
So
subdivision of 4 to 8 questions will be there. It can be
visible now, sir.
Not it. Match the following. Fill in the blanks, CT scan, technician scans, ultrasound, or some reflexes. These will be kept in the OSCE pediatrics. Counseling session or growth chart or some syndromes.
Still not visible, sir, because it is visible on my system.
Oh, ma'am, do one thing. Just stop share your screen. Okay. Then open your PPT and then share the screen.
Okay.
Yeah.
I thank Dr. Javinder for answering the madam's question. At the back hand, he is doing a lot of work. Thank you, Dr. Javinder, for answering all the questions of the audience.
Thank you, Doctor.
I thank all the participants. Yeah, now it is visible.
Okay.
So we'll be giving 30 seconds to answer all the questions. Please think over. Again, this PPT will be shared in the Telegram. So you should be very much attentive and you must be very much aware. And you should know that OSCE, when we are doing, you cannot carry over the papers of previous answers to the next question. So we have to put the answer chit in the box. So be ready. Over to you.
Okay. So very good evening. We'll start with our OSCE. We'll have a total of 7 stations, as Dr. Amarnath already mentioned. And you will be getting 30 seconds for each of the station. And if it's a complicated question, you'll get more time. So we'll start with our first station. A 9-year-old girl presented with a history of excessive sleepiness, constipation, and short stature. On examination, there is dry skin. She had a grade 2 diffuse non-nodular symmetrical bosselated goiter. Her height was less than 3rd centile, while weight was preserved, that is on 25th centile. Biochemical investigation was suggestive of a high TSH, 952 international units per ml, with a very low free T4 of 0.5 nanogram per DL. So these are the questions. So this is the growth chart with the weight on 25th centile and height less than 3rd centile. From the growth chart, calculate the height age and the weight age. What other biochemical investigations or radiological investigations you will order? What is the treatment of choice with dose in this condition? And how would you monitor the child? So your time starts now.
Yeah, ideally you should have a growth chart at your hand. Otherwise it's not possible. Other questions you can answer. You should have a scale also to get the chronological age and the weight age and height age.
They have to answer all 4 questions in 30 seconds.
No, you will get more, but we don't have a time. We are giving for just thinking. They will have a 5 minutes time. We don't have a time here, sir. You can answer B, C, D. Try.
So should we take the answers?
Yeah, go ahead.
So here you can see for height, age, and weight age calculation, I think everybody of you must be aware that you have to draw a parallel line to the x-axis from the plotted height till it reaches the 50th centile line, and then you have to draw a perpendicular line till it reaches the x-axis. So that would give you the height age, and in this case the height age is 5 years. Similarly for weight, draw a parallel line, then draw a perpendicular line. So the weight age here is 7.9 years. So if you can see, the height age is more affected than the weight age, and it is expected in any endocrine cause of short stature. Other investigations we would like to order is anti-TPO antibodies and anti-thyroglobulin antibodies, as it's a case of, most likely a case of acquired hypothyroidism. And we can definitely do a USG thyroid to look for any ectopic thyroid if it is there. Treatment of choice would be levothyroxine at a dose of 1 to 2 microgram per kg per day. So here we would start with 25 microgram per daily, since she has a weight of 24 kg. And as Dr. Ravindra clearly mentioned, that first thing comes is the clinical monitoring. So you have to monitor height and weight at regular intervals, maybe 3 monthly. And for biochemical monitoring, we have to repeat TSH and free T4 after 6 weeks of starting dose, and then every 3 monthly. But whenever we are changing the dose, again, you need to repeat your TSH and free T4 after 6 weeks of any dose change. So we move to our next question. This is a 4-year-old boy who presented with significant speech delay in pediatric OPD. On history evaluation, his 14-year-old sister also has a hearing loss and a goiter, and they both are born of a first-degree consanguineous marriage. Again, the weight is on the 10th centile, that is minus 1.2 standard deviation, but his height is less than minus 3 standard deviation. So what is your likely diagnosis? What are the characteristic features of this condition? How would you confirm your diagnosis? And how would you explain goiter and hearing loss in the same patient? What is the mode of inheritance of this condition? Your time starts now.
So multiple systems are involved. Syndrome, you should think.
I think there are
already made it clear actually.
I think there are 3 postgraduates, so I think we can just immediately ask them the answer. If they are able to do it, then okay. Otherwise, we can continue.
Yeah, 30 seconds over. Yeah.
So can we ask the postgraduates, or we move to the answers?
Just run like that. They will see. We don't have a time.
Okay.
Yeah.
So the syndrome is Pendred syndrome, has already taken beautifully by Dr. Vandana Jain madam. It is characterized by congenital sensory hearing loss and a goiter. And the mutation is in iodide transporter, potassium iodide transporter. So we have a gene panel which are responsible for the mutation in this particular transporter. And why there is hearing loss? Because the same transporter is there in the inner ear, which leads to hearing loss, and this channel leads to thyroid dysharmonogenesis, leading to reduced organification of iodine, and that is why hypothyroidism. And the mode of inheritance is autosomal recessive. This explains both brother and sister having the same disease. So our next patient, a 5-year-old girl who was previously well, presented in PICU with a history of weight loss, loss of appetite and sleep difficulty. On examination, she was hyperthermic. She had a toxic look. She had tachycardia, hypertension, resting tremors. Her peripheries were warm. She had an exophthalmos and a small goiter, grade 1, which was non-nodular and diffuse. ECG leads were suggestive of left ventricular hypertrophy. And she had a positive family history of paternal grandfather taking treatment of hypothyroidism. So you have to name the condition. What is the expected thyroid function test in this condition? Name the scale which is used for the diagnostic criteria of the condition. Name the specific antibodies which can be ordered after stabilization, and 3 drugs which you will use in this patient to manage the condition. So your time starts now. So I think all of you have the answers in their mind. So we'll go to the answers. So it is thyroid storm with hyperthyroidism. It is a very close DD of hyperthyroidism and thyroid storm. But since our patient had a toxic look, tachycardia, and ECG was suggestive of left ventricular dysfunction, so the diagnosis is thyroid storm. We would expect a decreased TSH and elevated free T3 and elevated free T4. For diagnostic criteria, we use Birch-Watowski point scale, which is mainly used in adults, but sometimes it can be used in pediatrics as well. The specific antibody associated with hyperthyroidism are TSH receptor antibodies, or we say is TRAB as well. And you will give antithyroid drugs, that is carbimazole, beta blockers, propranolol, to reduce the autonomic activity, and steroids, or usually we give prednisolone for anti-inflammatory action. And it also inhibits the T4 production. So this is just the diagnostic criteria for thyroid storm. It's given in Nielsen. Now you have to interpret these thyroid results. This is the answer key. You just have to mix and match. Very high TSH, low free T4, and low T4. So we'll give 10 seconds for each question. A normal TSH, low T4, and normal free T4 is expected in which condition? Everything low. Low TSH, low free T4, low T4. Now everything high. High TSH, high free T4, high T4. Last, you have low TSH with high T4 and high free T4. So again, just 10 seconds to fill up your answers.
Yeah, see the answer key there. Like match the following.
So I think you have matched it perfectly. I'll take the answers. So very high TSH, low free T4, low T4 is seen in primary hypothyroidism, as already taken by Vandana ma'am and Ravindra sir. Normal TSH with a low T4 and normal free T4. Again, it was taken by Ravindra sir, so it would be seen in thyroglobulin binding deficiency. Low free T4, low TSH, and low T4 would be seen in secondary or central hypothyroidism. Everything high, it goes in favor of thyroid hormone resistance. And low TSH, high T4 and high free T4, as seen in our previous case as well, is seen in thyrotoxicosis or Graves' disease. So we move to our next question. So we have done thyroid scintigraphy in this patient. Technetium scan was done. You have to tell the condition A, P, and the next question is you have to name the radiological scan of choice for diagnosis of thyroid dysharmonogenesis. Take the answers. So this you can see that the uptake is taken by salivary glands only. There is no thyroid gland uptake. So this is a case of thyroid agenesis. Here, the normal position of thyroid is in the midline here, but it is lying at an upper position of the normal expected position. So it is ectopic thyroid. And for thyroid hormone dysgenesis, we'll do a perchlorate discharge test. This is just the procedure. So you have to do a perchlorate discharge test. Moving to our next station. A 10-year-old boy presented with painless increasing size of both the testes. His height is less than 3rd centile and he has just grown 2 centimeter in the last year. So it's a poor growth velocity along with short stature. The weight is preserved and it is on the 75th centile, and he has a delayed bone age, that is 7 years at a chronological age of 10 years. So name one condition where precocious puberty with short stature and delayed bone age is seen. What investigations you would like to order in this case? What is the cause of testicular enlargement in this particular condition? And tell us the management.
So very interesting phenomena. Thyroid can cause both precocious puberty and delayed puberty. Previous case was delayed puberty. Now something different.
So we'll take the answers. I think everybody is ready with the answers. So this is a primary hypothyroidism with peripheral or pseudo precocious puberty, a syndrome, a specific syndrome which is called Van Wyk-Grumbach syndrome. You will order free T4 and TSH to confirm hypothyroidism and an LH, FSH and testosterone to rule out, to confirm peripheral precocity. You will expect a high FSH and slightly raised LH with a low testosterone. And the phenomena responsible for this is molecular mimicry, that is TSH and FSH have a common alpha subunit. So if high TSH, that causes high FSH because of this common alpha subunit. So that gives rise to testicular enlargement in boys, and in girls, it gives rise to breast development, ovarian cysts, and sometimes isolated vaginal bleeding as well. But the catch here is short stature and delayed bone age. And again, the treatment of choice would be thyroxine replacement at a dose of 1 to 2 microgram per kg per day. So we are coming to our last station. A newborn baby on day 7 found to have a newborn screening TSH of 256 international units per ml. Baby is having jaundice, excessive sleepiness, lethargy, and poor feeding. So you have to counsel the parents regarding further management. So we'll take the answer. So whenever in DNB OSCE or in postgraduate OSCE as well, whenever you are asked to do the counseling, first of all, we have to introduce ourselves that you are a doctor or whether you are an MD doctor or whatever. And then you have to congratulate the patient for having a baby. And then you have to talk about the physiology of the particular condition, then about the pathology, followed by treatment and specific advices. And in the last, you have to ask whether they have any questions or not. So we'll start with the physiology of thyroid gland, that in most babies with congenital hypothyroidism, the thyroid gland may not reach its proper place in the neck during development, or it may be very small or even missing completely, as in cases of thyroid dysgenesis. Usually, there is no family history of congenital hypothyroidism, but in certain percentage, 20 to 20%, who are having thyroid dysharmonogenesis, we can have a family history of sibling affected with hypothyroidism. So you need to tell them that if it's thyroid hormone dysharmonogenesis, their second baby is having a slightest chance of having congenital hypothyroidism. Then we have to tell them the treatment modalities. Already we have done biochemical investigations, but to prove our diagnosis, we need to do imaging and USG. Then next question comes, are they safe? So we have to tell them that thyroid scans are very safe and they can give us the information about the type of hypothyroidism and whether it's likely to be permanent or not. Then we have to tell them that children with congenital hypothyroidism are able to do all activities normally as long as the treatment is taken regularly and in appropriate doses. And the treatment is just a medication by mouth that has to be given once daily. So what the body is not making, we are giving it through an oral medication. But important is to tell them that they should start their treatment promptly. As already told that 14 days is the lead time. So as early as possible, we have to start the treatment to prevent further mental retardation. Again, then comes that whether treatment is effective or safe. So we have to tell them that it is safe and effective. If taken in appropriate doses, it should not result in any side effects. It has to be given every day orally in the morning. They can crush the tablet because syrup suspension is not available in India. So they can crush the tablet, either mix it with breast milk or directly put the crushed powder in the baby's mouth and breastfeed. So whatever they feel comfortable, they can do. The child can have all the usual immunizations or medical treatment needed for other conditions. She doesn't need to eat any specific diet because of hypothyroidism. Certain medications like iron and calcium supplements may interfere with the absorption of thyroxine. So it is advisable that they should keep a gap of at least 4 to 6 hours between these supplements and the thyroxine dose. And in the end, you need to ask their doubts if they have any. And then you just need to tell them when they do need to come for the next follow-up. So thank you. If you have any doubts, you can ask.
Yeah, thank you, Dr. Ankita, for the excellent presentation. Please note the aim of ASCII 50% is very easy, 25% is little tough, 10 to 25% is beyond the reach. So you have to work hard, do ASCIIs every week so that it will be easy. Let me ask few more ASCII, 1 or 2 within 1 second. Suppose hypothyroidism child coming with the calf hypertrophy. What you call that? Think over. Like that, so many questions can be asked. So we don't have a time. Coker-Debris Smerian syndrome. So, Raghupati sir, you want to tell anything, sir? We are coming to just last 1 or 2 minutes about the question and answers.
I was saying that even thyroid can be challenging, and we may be caught. Can you see my slide?
Yes, sir. Now.
Okay, these slides I have already shown you.
Yes, sir.
And we should not wait till this stage. And this is an ectopic thyroid, which you can see it's already been shown. This is an extreme case of dysharmonogenesis in the newborn period. I mean, by this time it was actually 3 or 4 months. And if newborn screening is done, this could have been avoided and the treatment could have been better. And this is an extreme case. This is a boy who has completed his 12th standard exam and he is 18 years old, 17 years old. And
sir, your slide still at first, sir. You should go to 5th slide.
You can't see?
No, you are showing the slideshow is not visible, sir. We are able to see only first slide. You have to go to slideshow. Or you go to slide 5. You are telling about the slide 5.
Here it is moving.
Yeah, no problem, sir. We are able to see small photo of, yeah, you can tell, sir. Small photo we are able to see in the
and this boy, he said, is 17 years old and he came with short stature, and I was horrified to see that he is a case of hypothyroidism. But to my surprise, he is a very good student, and he has done quite well in his exam, and he even passed his exam also. So we do have some challenging situations like this. And the next case that I want to show is one which I was seeing in my clinic, and I remember Amarnath was with me when he was doing the training. And this girl was diagnosed as autoimmune hypothyroidism, and I had started treatment, and the parents came and said, ever since this treatment was started, the child is sleeping all the time. I couldn't believe it. But fortunately, it was in the evening. I saw this child. I don't know whether you can see the slide, but she was sleeping in front of me. Then I said, this is myasthenia gravis. You know, both are autoimmune conditions, and this is a very, very rare thing to happen. But as I said, we need to be aware of all these problems. And
yes, sir. Now visible, sir. Yeah. So this is a potential ASCII for you. They can ask most common other autoimmune diseases, type 1 diabetes. You should know. And I wanted to congratulate and thank sir. He showed me based on growth chart. Child was coming for the hypothyroidism. He diagnosed diabetes based on only growth chart, loss of weight. So please try to learn from the professors. Just by growth chart, you can diagnose many diseases. Thank you very much, sir.
With the treatment, they bloom and blossom, you know, and it's a pleasure to see these children improving with the treatment. And if you start treatment early, they'll blossom from the beginning itself. Thank you.
Thank you very much, sir. So we'll go to last just 1 minute. We'll look over the questions, what has been asked in the last few years. Can you stop this thing, screen sharing, sir?
Yeah. Where is it?
Thank you, sir. Hope my screen is visible.
No, Dr. Amar, your sir's screen is still visible. Your screen is not. Yeah.
Sir, you have to close the screen. Don't minimize it.
Yeah. Now your screen is visible.
Is it visible?
Now it's visible.
Yeah. So I'm sorry. So I'm DNB examiner also. Please note, whenever you're writing theory answer, please write in side headings. Please use 3 to 4 flowcharts, diagrams, maximum tables you should write. Then only you'll get good marks. So it should not be monotonous. This is from the Nelson, developmental physiology. The questions are like synthesis and its derangements. What are the changes seen in thyroid hormone levels around birth? Describe the silent features of neonatal thyroid screening program. This is most important. It's available in net. You can download. That is ISPE guidelines, national guidelines. Interpretation of thyroid function test. This is told by already Dr. Ravindra Kumar sir, and also we had ASCII. So hypothyroidism, commonly diagnosis endemic cretinism. This is outdated. We don't use cretinism at all now. Congenital hypothyroidism, etiology of congenital hypothyroidism, neonatal thyroid screening, again, causes, clinical features, acquired hypothyroidism, discuss synthesis of thyroid hormone, discussed by madam already, common causes of acquired hypothyroidism in 12-year-old girl, discuss brief clinical manifestation of laboratory diagnosis. So screening and treatment of congenital hypothyroidism. Thyroiditis, briefly list the various thyroid function tests, describe clinical presentation and management of autoimmune thyroiditis. So these are the, from the goiter, management of puberty goiter. Once there was a question on grades of goiter. So management of pubertal goiter and goitrogenic hypothyroidism. They can ask question on hyperthyroidism, childhood hyperthyroidism. Thank you very much, sir. I thank all the panelists, especially ISPE, for giving this chance to me. Over to Javinder.
Yeah. Thank you, Dr. Amarnath. So I thank you, all the panelists, all the participants for their active participation, and many questions were asked. So I thank you, Aila ma'am, Vandana ma'am, Ravinder sir, Dr. Mahesh, Dr. Ankita, Dr. Deepsika, Dr. Pooja, and Dr. Disha have done very good job. And thank you, Dr. Raghupati sir, for the teaching lessons. Sir has a huge experience and he gives us the life-changing lessons in between. And Dr. Amarnath for the persistent hard work. It's his passion which has brought life in this PEP program. And we hope to see you again on 21st June 23 for the second PEP session.
Yeah, next session will be very interesting. It's diagnostics in pediatric endocrinology. So don't miss. Now I request Raghupati sir and final remarks from the speakers. Anything?
I was very pleased to see the number of participants as 143 at one time. I don't know whether it was higher.
Sir,
went up to 150, sir.
150, yeah.
150.
Because it's gone all India, and I'm very, very happy to see the interest in pediatric endocrinology, and I hope you found this session very useful.
I congratulate sir. He cancelled his OPD and he came for the class. See the passion. So we are very young. We don't want to leave all our work, but being professor at this age, we should learn the passion and love. So see the blooming of the flowers and all. So that is the vision of professor. He wants all of us to be as like him and more than him. Thank you very much for your blessing, sir. I thank Dr. Ankita for hard work, Dr. Ravindra Kumar, Dr. Mahesh, and Javinder, Aila madam, everyone. Especially I thank all the participants. We wish you all the best. You should come with good colors, gold medalist. More than that, treating the patients, spending the time with the patient, having active interaction, see the thyronorm, see the medicines, see all signs, go to the lab, see the X-ray, see the ultrasound. That's what my professor used to say. So for each patient, you should go to the laboratory, discuss with radiologist, differentiate between testis and ovary, see the thyroid, what is a normal picture, technician scan, like that. So it should be a like a multi-tasked approach with all the specialists. I once again thank everyone, especially RIA and RX events. Though there was a small technical glitch in the beginning, they have done very well. We have posted the Telegram link in the Q&A session and also in the chat box. Later you can contact me, Dr. Javinder. Once again, thank you all. See you. Good night.
Good night. Thank you.